So this topic is geriatric considerations in urinary incontinence and overactive bladder. How many of you see overactive bladder in your practice? Yeah. How many of you see, a subset of your patient's geriatric population? It's something, yeah. So there's such an overlap, and we're going to talk about that. And so I tried to put a little lens on this field, kind of from the geriatric perspective, because by virtue of us being urologists, we're also geriatricians, and we need to kind of have that mindset. So here are my disclosures. They're going to kind of present this on each talk, but I do teach optimal lead placement technique for InterStim and Medtronic. I do donate all my honorarium to Virginia Mason, and I'm a site investigator for Axonics and Cook Myocyte. So I'll touch on those during my talks. So we're going to review geriatric concepts and the role of frailty, which you've seen in the literature. It's becoming a more popular way to look at the geriatric population. And we're going to look at some compelling data on anticholinergics and dementia. So we know the elderly population is growing rapidly and living longer. I mean, this is a segment of our population that we're going to need to address in a meaningful way. Similarly, as people age, the prevalence of overactive bladder and urgent incontinence in both men and women increase. If you're seeing someone who's 70, 80, they're more likely to have urgent incontinence, overactive bladder than, let's say, stress incontinence. Maybe they have a mixed picture, but this is a highly prevalent condition, and it increases as they age. So this is a study in which a group looked at NISQIP data, and they looked at stress incontinence sling procedures, and they found that the gynecologists are performing 3/4 of the sling procedures. So they just have numbers that we don't, and the urologists are performing about a quarter of those sling procedures. They're performing them at the time of concurrent surgery, but we're operating on patients that are older, I should say, and with more comorbidities. And so this sort of reflects our population. We have this population in our surgical subset. We're also performing a greater proportion of autologous fascial sling procedures, which we have that skill set. And so it just sort of validates and verifies that we're dealing with these more complex patients. So we want to go over some geriatric concepts, and I have a collaborator who's a geriatrician at University of Washington, which is down the street from us, and some of these slides are from a talk that she gave. I said, I want you to come and I want you to teach our fellows about geriatrics. And she was like, okay, I'm going to do something for the surgeons, and I'm going to hone in on what you surgeons need. And so some of these are her slides, but she was like, you need to know about the 5 M's. This was introduced in, let's say, 2017 in the geriatric world, and they're trying to push out what they're doing to the primary care and to the specialists. So it's five things: mind, mobility, medications, multi-complexity, and what matters most. And so we're going to go over each of these. So the mind, this makes complete sense to us. How are they mentating? How are they doing cognitively? We certainly have people who come in with dementia, in the hospital setting, delirium, and depression. We see this in our daily practices. So to be cognizant of this, to think about this, there's a strong association of incontinence and depression. If they have incontinence, they're almost twice as likely to be depressed. And it's a cycle, right? They're incontinent, there's downstream effects of that, they're depressed, or they're depressed and, kind of letting things go. So again, to kind of be aware of this. And sometimes, I have these visits with patients and it's more about their depression than their incontinence, but they're here to see me for their incontinence. So I also feel like we also have this GU psychiatry hat that we have, but that's a side issue. Mobility, again, we see this in our daily practices. You got the people with their walkers and the wheelchairs, and they're slow. They have a slow gait. They have balance issues. And so this is an issue that affects their incontinence and their overactive bladder. It's intertwined. It's one and the same. It also might be related to, like, they fractured a hip, and they're dealing with the downstream effects of that as far as their ability to get there. So we know, again, patients with incontinence have a higher risk of falling and fractures. And this hip fracture is then associated with morbidity and mortality. And so we need to kind of be on the up and up with treatment of overactive bladder incontinence as it affects this. So this is a concept that everyone knows about stress incontinence, everyone knows about urgent incontinence, everyone knows about overflow incontinence, and even intrinsic sphincter deficiency and all these sort of subsets of incontinence. But functional incontinence is something we see all the time, and I just want to highlight it because it affects the geriatric population a great deal. So it's one or more physical or mental reasons that are impairing their ability to make it to the bathroom. Okay? So if it's cognitive, you definitely have seen these patients. They've got Parkinson's, Alzheimer's, they're demented, and they can't put it together to get there. That's their barrier. And so for these people, they come in with their caregiver or their spouse, and we're like, we need timers, we need reminders, we've got to support them to get to the bathroom. And that can often mitigate the issue, We've got we were talking about mobility. They need more warning time. They've got that urge and they've got about, this amount of time to get there, but they can barely, get across your clinic space. So these might be environmental barriers, right? Think about the path that they have to go from their bed to their bathroom, and how can, what's in the way? So sometimes you have to bring the bathroom closer, right? Be creative with your solutions. Think about their situation. Maybe it's a bedside commode. Maybe it's a urinal. Maybe it's, there's different things that you can do to help get there. And this can be temporary or long-term. Often these are people who have worse symptoms after they're slowed up from a hip fracture and they're recovering, and you're like, okay, I think when you get back to your baseline, it's going to be much better. Or it's a long-term thing, right? Like this is their new state, and we've got to work with it. Sometimes it's manual dexterity. You've got patients who talk about, I can make it to the bathroom, but then I'm like, can't get my pants undone quick enough, and it's like running down my legs. So I've had people modify their clothing, Velcro, make it fast. Little things to help improve their quality of life. And patients and their families love having these solutions and actually having someone think about this way. So functional incontinence. It is actually an ICD-10 code. I like to put it as a sub-code under urge incontinence, because you need, the urge incontinence code to get sort of approval for other things, and kind of, it is sort of the umbrella of what they're dealing with, but it's something a little different. So medications, polypharmacy, prescribing, like simplifying their medication list, optimal prescribing, thinking about their renal function and things, as well as the adverse medication effects and the medication burden. We're going to talk about this more, but anticholinergics in older patients, it's a big deal. They're more vulnerable to side effects and toxicity. They have a slower metabolism and elimination of the drug. They have changes in their blood-brain barrier, changes in their muscarinic receptors. The number and distribution happens with aging and dementia. There's age-related deficits in the neurotransmission processes. And there was a study that looked at nursing home patients. A great deal of them are taking 2 or more anticholinergics, 3 or more anticholinergics, 5. And so, that study was a little bit older, and so hopefully, we're kind of making progress on this. We've also got to think about their medical complexity. These are multi-morbid people with lots going on, and they've got complex bio, psycho, social situations. And so just to have an understanding of that and kind of frame what's going on. So it's not just their hypertension and their diabetes and their urinary issues. So we've got the 5 M's: mind, mobility, medications, multi-complexity, but probably this one matters most. And it's what matters to the patient. I think that you have to think about their own preferences, their goals. And I think as far as incontinence and overactive bladder, this is what it's about. So often we'll talk about all the symptoms, we'll get a sense of the severity, the duration, but then I'll say, what bothers you the most that we can work on? So kind of honing in. And then I'll say, and what are your goals? What would you like more of? And it can be something as simple as, my ladies who live in sort of an assisted living or nursing home facility, and they say, you know what, I would love to go on these like daily field trips. I want to get on that bus and go to the museum or whatever. And I say, and I've stopped going because I can't, my bladder is out of control. And so I think we can get you there. I think we can get you on that bus, And so then it just gives us a goal. And then, a few visits later, things have worked out, and they're like, I'm going on those trips. Or maybe, so everyone has a sense. Sometimes you have to actually tone down the expectations, but often it's manageable. So I think that's important to keep in mind. So those are the 5 M's of geriatrics. We've got mind, mobility, medications, multi-complexity, and what matters most. All right. So now we're moving on to a different concept, which is frailty. This is defined as the decline in physiologic reserve and function among older adults, and it's associated with an increased risk of poor health outcomes. Multiple studies in multiple fields have shown increased rates of postoperative complications, decline in functional status, longer hospital stays, higher rates of discharge to skilled nursing facilities. And so there's sort of this idea of, someone who's robust, someone who's pre-frail, frail, and as their performance and homeostasis declines, they're getting these negative outcomes. And it is somewhat associated with age, but it's independent of age. So there's many assessments of frailty, and one of the sort of gold standard research level assessments of frailty is called the Fried Frailty Phenotype Assessment. They're looking at grip strength with a sphingometer, it's hard to pronounce, but it's basically this thing where you have to grip this thing, and so weaker grip strength is a correlation of their muscle strength. Slowness, what's their walking time for 15 feet? What's their physical activity level on a daily basis? And do they have weight loss, unintended weight loss, the kind that we just discussed? And exhaustion, are they getting slowed up? So that's kind of sort of the gold standard out there, but it's cumbersome. It's a lot of assessments to take. The time get up and go is also a popular way. You get up, you have to walk 15 feet and walk 15 feet and back. And the time it takes you is a marker of your frailty level. And so another frailty measure, which is more of a gestalt, it sort of would fit better into our practices. It's an eyeball method. You get to assess your patient by, you know them, you can ask, you're asking them questions about their lifestyle, but it's essentially a 9-point scale. Number 1, very fit. I mean, these are people who are working out. These are your 90-year-olds who are still playing tennis. Well, they're no active disease, but they're not really as active or active occasionally. Ones that are managing well, their medical issues are well controlled, but they're not regularly active, they're not walking much. Vulnerable, they're not dependent on others, but their symptoms are limiting their activities. They're tired during the day, they're slowed up. Someone who's mildly frail, they have more evidence of being slow. They need some help with higher order activities of daily living. And this impairs their shopping, walking outside, things like that. Then you've got the moderately frail. They need help with all activities. They've got caregivers. They're the ones that come in with the caregiver. Severely frail, they're completely dependent on others. And then you've got this is sort of end of life, severely frail. So this is this is used in the literature, and it's a good assessment. So our next step, so that geriatrician that I had mentioned earlier, who came and lectured to our fellows, inspired one of our fellows to get interested in frailty in our population, in sort of our female pelvic floor population. And we developed a project. The project was actually a flipped hypothesis. So instead of saying frail people do bad with female pelvic floor surgeries, incontinence surgeries or prolapse surgeries or OAB procedures, it's saying, they might do okay. They're going to do okay because this is the population that we work with, and our procedures are particularly low risk with low rates of complications. So we prospectively looked at measured frailty in these patients, and then they went on to have surgery, and we compared our frail and non-frail. So we assessed them as surgeons, the fellow assessed them, the patient did a self-assessment. We use this CFS-9 scale, and so we have this posted in our clinic now. And then we also did all the other ones, the grip strength, the walking, we compared all this sort of standard. And what we were able to show is that it correlated nicely in the area under the curve. So this was, the eyeball method was as good as all the other methods. And then what we showed was their complication rate wasn't higher. They did just as well. And so we were able to kind of, validate this method that's more clinically useful and compare it to the standard, the reference standard. Another frailty study that we were involved with was a NISQIP study. So 2/3 of all urologic procedures are performed in patients over 65. So we're already, engaged with this population. So we looked at the 20 most common urologic procedures in the NISQIP database, and we looked at all these frailty measures, indexes. And what we actually showed was that the ASA actually slightly outperformed the other measures. So it's not saying that the indexes are bad, it's saying that it's a little more complex and more studies are needed. How do we predict who's going to have a complication? So more to come on frailty, and keep an eye out on those the things in the literature. So we talked about the 5 M's, we talked about frailty, and now we're going to talk about anticholinergics. So anticholinergics are a big category of medicines. Our bladder medicines are just a portion of that. Antidepressants fall into there, antihistamines, the incontinence and OAB meds, and then the antipsychotics. So we're talking about anticholinergics, we're talking about the whole family, but ours is certainly a big proportion of those. So this was a 2015, I would say, landmark study on the cumulative use of strong anticholinergics and incident dementia. This was a prospective cohort study, actually performed at Group Health, now Kaiser, in Seattle, by an internal medicine group and this group of researchers, and they looked at this population base, mean follow-up of 7 years, and they were able to show that a 10-year cumulative dose relationship was observed for both dementia and Alzheimer's compared to those who weren't using anticholinergics. These results were robust to secondary sensitivity and post-hoc analyses, and it showed that a higher cumulative anticholinergic use, greater than 3 years, was associated with an increased risk of dementia. So this made it to the lay press. Your patients, will read about this and will ask you questions about this. So these are the kind of studies you need to know about. So more studies came out, and then this one I would say was another landmark study, 2019, also published in JAMA of Internal Medicine. It's a nested case control study, and it looked at 58,000 patients and their total standardized dose of anticholinergics, and they were able to show a dose response. So exposure and higher response or higher correlations. So these are associations and these are correlations, but it's something to think about, and this is anticholinergic use 1 to 11 years before their dementia diagnosis, okay? So the data is accumulating and it's compelling. Multiple other studies, are in the literature, but I think it's something important to counsel your patients on. We're prescribing these medicines, they're part of our armamentarium, but I would say, there are studies, you may read about this, you should know, these are long-term studies, we're monitoring this, data closely. We still think it's safe. We're gonna do a trial, I'm gonna monitor you closely, I'll see you back in, a month, 4 to 6 weeks, and we'll go from there. So I like to reassure my patients, because certainly we've been doing, using these medicines for years, but I also like to just kind of clue them into it so that they know that we know that this is going on. So geriatric considerations in treating overactive bladder and urgent incontinence. Certainly you want to optimize first-line therapy. So the OAB guidelines and the AUA apply to this population as well. We want to optimize first line, consider second line, and then move on to third line if they so need it. The study at the bottom of the slide is the impact of frailty on treatment of OAB. So basically they showed frail and non-frail patients did just as well in 3 months with either meds or second line therapy or third line therapy. So beta-3 agonists are certainly out there, and I'm sure you're prescribing them. This was a meta-analysis that looked at mirabegron was more efficacious than placebo. It was about the same as other active treatments. It was better tolerated by dry mouth, constipation, and retention. There is that risk of hypertension. And the main issue is cost and coverage. It's getting better. And there are more beta-3 agonists coming down the pike, and so we'll have more options. Percutaneous tibial nerve stimulation. The data is good. This is a popular, people are interested in this. The patients like it. It's very low risk. It actually probably has less side effects than meds. There's no predictive factors that have been identified to predict their rate of response. Many have concurrent therapy or move on to other therapies, but it has been shown to decrease their risk or their use of anticholinergics. One study looked at a real-world experience and showed that these are older patients that are getting this. Mean age is 75, they're women, they're married, they live within 7 or 8 miles of their practice. 70% improved, and the most common reason for noncompliance was lack of efficacy. So future directions for PTNS, implantable, leveraging more technology. Botox in the elderly, also the data shows good efficacy in the older populations. I think our tendency is are they gonna do okay? But they do well. There is data to show they have an increased risk of incomplete bladder emptying, which makes sense based on the mechanism. Slimmer rate of UTI, well tolerated, satisfaction is high. Just wanna mention sacral neuromodulation, and we did a study on octogenarians, and showed that they do just as well as the non-octogenarian population, so advanced age alone should not preclude. We looked at another study that looked at how are they discontinuing meds after sacral neuromodulation, and 80% at 1 year are no longer on their meds, which is a good outcome for them. So in summary, you get the thing. Thank you.